Bismillahirrahmanirrahim. This video is the fifth video in the series of acute and chronic inflammatory dermatosis, and this video will cover psoriasis. These are the references for this video. Now, the chronic inflammatory dermatosis that persist for months to years, and these are characterized by roughened skin surfaces, and these are due to excessive or abnormal scale formation or shedding. And the conditions that we are going to study under this head are psoriasis, seborrheic dermatitis, lichen planus, and granulomatous dermatitis. Psoriasis is a proliferative and frequently familial skin disease with persistent epidermal hyperplasia. The etiology of this psoriasis is considered as autoimmune. It is prevalent in 1 to 2% of the cases, and all age groups are affected by this disease, but peak incidence occur during late adolescence. The ethnicity, it is not seen in Native Americans and it is infrequent among Asians. The associated lesions of the psoriasis, one of the lesion is arthritis, and 15% of the psoriasis cases are associated with arthritis. Some cases are mild, while uh, they may show the deformities like rheumatoid arthritis. Any joint can be involved, and it can be associated with symmetric or asymmetric involvement of the joints. It is associated with myopathy, enteropathy, and AIDS. Psoriasis is a multifactorial disorder. It is considered that it has got genetic association, and 1/3 of the patients they show a positive family history. The severity of the illness is associated with the likelihood of familial background. More severe a disease or more severe the psoriasis, it has great likelihood of familial background. There are some observations that support the concept that this is a genetic disease. First, it has got an increased incidence in relatives and offspring. 65 concordance is seen in monozygotic twins. It is associated with some HLA haplotypes such as HLA B13, HLA B17, HLA B57, and particularly HLA CW6. See, this HLA CW6 has got 10 to 15 fold increase susceptibility to this psoriasis. A genetic determinant of the susceptibility is a 300 kb segment in MHC1 region of the chromosome 6, short arm of the chromosome 6, that is termed as source1. This disease is also linked with immunological factors. The lymphocytes, T lymphocytes, are important in the pathogenesis of the psoriatic lesions. The T helper 1 and Th17 cells, that are the subsets of the T helper 4 CD4 cells, they are important for the initiation of inflammatory response and development of dermatosis. These cells, the helper cells as well as the effector cytotoxic cells and antigen presenting dendritic cells, they are all responsible for secretion of cytokines, various cytokines that are interleukin, such as interleukin 12, 17, 22, 23, and gamma interferon and tumor necrosis factor, as well as the epidermal growth factors, keratinocyte growth factors. So the combination of these all these cytokines and epidermal growth factor, they initiate the changes in that are seen in the psoriasis. Hence, these cytokines, the interleukin 12, 17, 22, 23, interferon, gamma, and TNF, all are the therapeutic target for this disease. This disease is also linked with environmental factors. The clinical lesion of the psoriasis occur anywhere on the skin. Physical injury, infection, drug, photosensitivity may produce psoriatic lesion in apparently normal skin. The chronic rubbing of the skin can also form psoriasiform lesion, but these psoriasiform lesions disappear after the stimulation or the inciting agent or inciting stimulus ceases. But in psoriasis, even the less trauma generates a large lesion, and this plaque persists for years even after injury. Now, the pathogenesis of the psoriasis, as seen in other autoimmune diseases, the psoriasis is the product of environmental and genetic factors, but the antigen that is responsible is still unknown. There is colonization or homing of the skin by the sensitized CD4 cells and activated CD8 or cytotoxic cells. The helper T cell subgroups are Th1 and Th17, and they enter into the skin and accumulate within the epidermis. The interaction of these lymphocytes, the CD4, CD8, the dendritic cell, and the keratinocyte, there is secretion of various cytokines and growth factors, and a microenvironment is developed. This leads to keratinocyte proliferation and epidermal thickening. The cytokines that are released are interleukin 12, gamma interferon, tumor necrosis factor, and interleukin 17. These are so much important that one of the important therapeutic agent is TNF blocker. This tumor necrotic factor is blocked, and it gives a very good result in the therapy of the psoriasis. Robbins' textbook of pathology describe this scenario as a soup of cytokines that is present in that microenvironment. There is another important concept that is termed as Koebner's phenomenon. This Koebner phenomenon is when these psoriatic lesions can be induced in susceptible individuals by local trauma. When there is minor injury, a psoriatic lesion is developed, and this may be large. And now the morphology of the psoriasis, the common sites for this lesion are elbow, knee, scalp, lumbosacral area, intergluteal cleft, and glans penis. Initially, the lesion is erythematous, and there is inflammatory reaction with pustule formation. As is evident by this picture, there are numerous pustules that are present on this skin surface, and whole of the skin is erythematous. Later in its course, as the disease becomes chronic, there is well demarcated pink to salmon colored plaque that are covered by loosely adherent silver white scales are present. There is a wide variation in the shape of the lesion, The shapes may be annular, linear, gyrate, or serpiginous, and this psoriasis is one of the uh, cause of erythroderma, that is total body erythema along with scale formation. Nail changes are also seen in 30% of the cases of psoriasis, and they are characterized by yellow-brown discoloration that are like an oil slick, and there is pitting of the nail, dimpling, onycholysis, that is separation of the nail plate from the underlying nail bed, thickening of the nail plate, and crumbling also seen. This is the gross appearance of the psoriasis. The erythematous plaques are present on the trunk, and these are large, confluent, sharply demarcated, and these lesions are also present in the intergluteal region as is seen in this picture. So this gross picture of the psoriasis is showing a thick silvery scaling lesion. These type of the lesion are common over bony prominences, scalp, genitalia, and hands. The epidermal turnover in the psoriasis is decreased from 27 days to only 4 days. The psoriasis is characterized by acanthosis, that is marked epidermal thickening, and this is due to increased epidermal cell proliferation. More, there is a regular downward elongation of the rete ridges, which give this rete ridges appearance of the test tube that are placed in a rack. So this is called test tube in a rack appearance of the in a rack appearance of the rete ridges. Mitotic figures that are normally confined to the lower basal layer of the epidermis, these can be seen in the upper layers regularly and increased in number. Then the stratum granulosum is absent or thinned in the psoriasis, and there is overlying parakeratotic scale is seen. Uh, In psoriatic plaque, there is thinning of the portion of epidermal cells that overlies the tip of the dermal papillae. And here, underneath, there is dilated tortuous blood vessel is present. This abnormal approximation of the vessel within the dermal papillae and the overlying scale, that is parakeratotic, and this is responsible for the clinical Auspitz sign, because this is in close relation with the scale. This blood vessel is in close relation with the scale, and when this scale is removed, there is multiple minute bleeding points are present over there. This is clinically known as Auspitz sign. Then spongiform pustules are also seen, and these are formed due to aggregates of neutrophil that are present within the superficial dermis. And the parakeratotic stratum corneum accumulation of the neutrophil form Monroe's microabscess. In pustular type of the psoriasis, there are large abscesses that are the accumulation of neutrophils, and they are present directly beneath the stratum corneum. This picture is showing the epidermal hyperplasia. There is presence of parakeratotic scale, and there are numerous neutrophils that are present in the superficial epidermis. So this photomicrograph is showing another case of psoriasis, and here there is presence of elongated rete ridges, and they are arranged as an interlocking pattern, Uh, these are alternatively reversed clubs and forming an interlocking pattern. And the dermal papillae are edematous, and these dermal papillae are beneath a thin epidermis, and it is termed as suprapapillary thinning, and this is responsible for Ospett sign, the scale that is present clinically, and it is it is marked by parakeratosis. When it is removed, there are numerous small bleeding points. Now this is another high power view of the case of psoriasis. Here the cleft papillae contain tortuous blood vessel. This is more evident in the central papillae. Here numerous cross section of the venules are present that denote that these are tortuous. Then here this photomicrograph is showing that the neutrophils are present in the upper layers, and these neutrophils migrate into the epidermis from the venulized capillaries at the tip of the dermal papillae. Now to summarize the histological features of psoriasis, there is downward elongation of the retirages, there is thinning of the stratum granulosum, the parakeratotic area that is prominent, there is presence of aggregates of neutrophils and spongiosis in the superficial epidermis and parakeratotic region, and the uh, the venule and these tortuous capillaries that are present in the dermal papillae, they come in close proximity to the scale. When the scale is lifted up, there is pinpoint area of hemorrhage that is termed as Ospett sign. Coming to the clinical feature of psoriasis, the presentation of psoriasis is variable and the disease has got intermittent activity. The familial form of the psoriasis tend to be more severe than the sporadic one, and the lesion of the psoriasis can be a small annoying scaly lesion over the pressure points of the body. Recall the Koebner phenomena, and uh, or these can be serious disorder that involve most of their skin, and often it is associated with arthritis. As far as the size of the lesion is concerned, it can be a small focus of a scaly erythema or enormous confluent plaque that cover a large part of the trunk, and we have seen a picture, gross picture of the psoriasis that is covering the trunk. The typical plaque is about 4 to 5 centimeter in size, and it has got a sharply demarcated margin, and it is covered by silvery scales or salmon colored scales. Ospett sign, we have also discussed it in histopathology. When the scale is detached, there is pinpoint foci of bleeding due to presence of capillaries underlying, and seronegative arthritis is seen in 7% of the patient because the disease is frequently associated with HLA-B27, and the disease resemble the sign and symptoms resemble that of the rheumatoid arthritis, but the disease is milder in these psoriasis. The disease that is involving the joints is milder and causes little disability as compared to the rheumatoid arthritis. We have seen a picture of pustular psoriasis also. Here, the neutrophilic pustules of Kojok dominate, and psoriasis is also seen in HIV patients, and here this psoriasis is severe and intractable. For the treatment of psoriasis, coal tar or wood tar uh, and anthralin have been used, uh, and these are the strong reducing agent. Tropical and systemic corticosteroids were also used. methotrexate that is used for severe and generalized psoriasis, psoralen that is ultraviolet absorbing compound that binds to DNA and decrease the turnover time, and it along with phototherapy is given to the psoriasis patient and it is effective. Synthetic vitamin A and synthetic vitamin D have also been used, and now the anti-cytokine therapeutic agents are also used in the treatment of psoriasis. As we have seen in the pathogenesis of the psoriasis, there are various cytokines that are involved, and important one, the TNF blocker, are now used for the uh, psoriasis patients. This is the gross appearance of the psoriatic lesion that occur after the treatment by PUVA therapy and psoralen and ultraviolet therapy. And here the scales of the psoriasis are less florid.